Assalamu alaikum. Hello, everybody. First of all, I would like to thank Dr. Mervet, the scientific committee, and everyone involved in this AFRA project. I truly believe that this initiative can make a real difference and help improve healthcare across Africa. My name is Amal Mahmoud. I am a consultant electrophysiologist from Egypt, and I am the co-chair of the Southern Cardiac Disease Working Group. This topic is very important. I mean, sudden cardiac death generally. Important to me on a personal level, not only as a doctor, because of real life cases I have seen, made me realize how critical early recognition can be. This is why I have a strong interest in spreading awareness and knowledge not only among cardiologists but also among general physicians, internists, all healthcare providers, and even general population. Because we are not always the first one to see this patient, we know. So today our goal is simple. We want to give a clear and practical roadmap that anyone can follow when dealing with a case of syncope. Before going into the details, we need to agree on one important concept. Syncope is not one disease. Broadly, it can be cardiac or non-cardiac syncope. And while most cases are non-cardiac, and while most cases are benign, the small percentage which is cardiac is the one we are most concerned about. They carry the risk. And this brings us to today's title. Not all syncope is benign. Most of us see almost daily cases of syncope, and most of the time we reassure the patient and move on. But the real challenge is not treating syncope. The real challenge is not missing the patient who might die suddenly. Syncope is very common, but not always benign. Some patients may have underlying cardiac disease and a risk of sudden cardiac death. So the real question is who is safe and who is not. Syncope is defined as a transient loss of consciousness due to transient global cerebral hypoperfusion characterized by rapid onset, short duration, and spontaneous complete recovery. Instead of randomly evaluating the patient, we need a structured approach. When a patient presents with fainting, we should think step by step. Mean what? We should ask some question in our minds. Was it truly loss of consciousness? If yes, is it syncope or something else? Non-syncopal loss of consciousness like seizure. If it is syncope, is there is a clear cause, etiology, trigger? And finally, and most importantly, is this patient at high risk? In other words, is this a cardiac syncope or not? Because this the step where we should never fail. Missing this patient means missing risk of sudden cardiac death. First, we start with initial evaluation of the patient. Initial evaluation composed of history taking, physical examination, ECG, echo, basic investigation. I want best to stress on the importance of ECG. ECG is mandatory. Now coming to the most important tool we have, which is history. The diagnosis of syncope is often hidden in the history, not only in the investigation, and not just the last episode. We need a detailed history of every episode. Personally, I spend a lot of time taking history, not only about the event itself, but what happened before, during, after, and even the day before. You can find the word changing the situation, changing your thinking, changing your decision. After the patient tells their story by himself, we guide the history. We guide the history with specific questions, questions that may lead to a serious condition, like was there is a prodrome, any palpitations, any chest pain, did happen during exertion or lying down position. We ask about position. Is there a family history of sudden cardiac death? I ask about unusual things regarding family history, not a direct question. Is there a sudden family, a sudden history of, sorry, a history of sudden cardiac death? No, I ask some questions, not direct, even. Uh, Car accident, drowning, death during sleep, during shower diagnosed as gas asphyxia, because sometimes these are not accident. This may actually be undiagnosed cardiac events, maybe channelopathies. These are extremely important because they help us identify high-risk patients. So the next question, what are the high-risk features? High-risk features regarding history, regarding examination, regarding ECG. So regarding الhistory, high risk features include any symptoms direct us to cardiac cause like chest pain, shortness of breath, headache, exertion, supine, palpitation before syncope, no prodrome, family history of sudden cardiac death, structural heart disease. All these direct our thinking to cardiac syncope. During examination, unexplained hypotension, severe bradycardia, systolic murmur, all may carry an structural heart disease like obstructive heart disease, ischemia, myopathy, conduction abnormalities. The most important tool with us is ECG. There are major criteria and minor criteria. Generally, any ECG abnormality must carry a risk, ischemic changes, conduction abnormalities, channelopathies, any abnormality in the ECG. So we need help. If I was not a cardiologist or not a specialist, I need help. But when we told about ECG, I need to remember that ECG not just a 12 lead snapshot, not just this simple method. If our clinical suspicion is high, we can go further with high lead ECG, exercise ECG, Holter monitoring, loop recorder, and even wearable devices. It's mean ECG is normal. Oh, okay, so everything is good. No, there is many methods of ECG. So, if the history suggests exertional syncope, history guides investigation. Another important thing about history. If the history suggests exertional syncope, we can do exercise ECG. If suspect arrhythmogenic syncope, we can go with long monitoring, Holter, our loop recorder, our event recorder, wearable devices. So times we feel even we see that situation many times. We feel helplessness if there is a strong family history with no clear cause of syncope. We do everything. We do everything with our patient, but we didn't find any abnormality. But there is a great suspicion about family history. Two of his family, his brothers, the mother, father. Even genetic analysis, EP study, we should respect our doubt, our thinking, our suspicion. We should respect it. This is, as we told, the common cardiac syncope, structural channelopathies. طيب, now I want to talk with us about with you about pitfalls or some situations make us doubt about syncope. Seizure versus syncope. Um, if the patient is labeled as having seizures, ECG should never be skipped. One of the most dangerous pitfalls in syncope is confusing it with seizures. Not every patient with jerking movement has epilepsy. Convulsive movement can occur in syncope due to cerebral hypoperfusion, and this creates a significant overlap. And we see that very frequent times. I personally saw a family who lost two of their children. Both were diagnosed as seizures. And when we screened the family, we found long QT syndrome. So this was not neurological. This was cardiac. This was red flag. But we lost two children. Yeah, this is a catastrophic event. So the message is very clear. Any patient diagnosed with seizures must have cardiac consultation, must have an ECG, and we should never exclude cardiac syncope. Another important pitfall is that having reflex syncope. Reflex syncope does not exclude cardiac syncope. A patient can have both. Most episodes may look vasovagal, but one single episode may be cardiac, and that is the dangerous one. We search for it. So again, detailed history or even of every detailed history of every attack is mandatory. Also, we should be careful with tilt-table test. A positive test does not mean the diagnosis is final. There are false positives. Even with true positive does not exclude a cardiac syncope. So we should never stop our evaluation based on one test. We should complete my evaluation step by step. On the other hand, there is a low-risk patients, apart from all we mentioned before, young patient, no personal or family history, no exertional syncope, no unusual triggers, and normal ECG. Everything is normal. These are more likely to be benign, but also still require proper evaluation. In many African settings, we may not have access to advanced investigations or specialized syncope units or centers. Referral system become very important. If you suspect a high-risk patient, don't hesitate to refer. Ask for help, involve a cardiologist, involve electrophysiologist when needed. Don't underestimate. To conclude, not all syncope is benign. History is everything. ECG is mandatory, even in patient labeled as seizures or any diagnosis else. Reflex syncope does not exclude cardiac causes. And even with limited resources, we can save lives by recognizing red flags early and referring appropriately. Thank you. Thank you, everyone. I wish you understand. I wish you listen to my message. يعني, I tried to deliver my thoughts and my message to you. Now, Dr. Azza will take us through more real cases where we can apply the approach in daily practice. Thank you.
Thank you, Dr. Amal, for this concise presentation. You give us a roadmap on how to investigate our patients and not to take things lightly in order to risk stratify patients. Now I will share with you some of my daily cases that I have met in my clinic to give you hints how we can easily miss the patient and how we can easily recognize him and save lives, as Dr. Amal had provided us with her roadmap. Syncope is a highly prevalent clinical condition. We meet several cases in our daily practice, in the ER and in our clinics. This symptom carries significance as its potential underlying cause may involve the heart, blood pressure, or brain, leading to a spectrum of consequences from sudden death to compromised quality of life. And various factors contribute to syncope, and adhering to a precise diagnostic pathway can enhance diagnostic accuracy and treatment. As Dr. Amal had provided, a standardized initial assessment, risk stratification, and appropriate test identification facilitate determining the underlying cause in the majority of cases. My first case is Yunus. He's a 10-year child training for competitive sports. I would like to share, to have it an interactive case discussion. Yunus is a 10-year-old child training for competitive sports. His mother reports a syncopal attack during training with complete recovery within few minutes. However, his coach attributed this for missing his lunch and not seek medical advice. 2 years later, on doing routine ECG before participation in a kickboxing competition, this was his ECG. The patient had, as you can see, evidently, he has an accessory pathway, and syncope was mostly attributed to this condition. However, it passed unnoticed because syncope was taken lightly. Okay. In another case, Mr. R is a 37 Egyptian gentleman working in Italy since 2011 in a restaurant. Few months ago, he injured his thumb with knife during work, after which he fell with complete loss of consciousness with complete recovery immediately. After transfer to the hospital for stitches, he was referred to have an ECG. And this was his ECG. Actually, I think in everyday practice, many people would have diagnosed this as a vasovagal syncope due to the injury of his hand and the scene of the blood with the while working. But however, it should have been taken seriously for any syncope. Yes, this is true. This is type 2 progada. Moreover, and so accordingly, the patient was taken into the channel of working for progada. Accordingly, all the workup for the suspected progada patients was done. Thereafter, the patient gave family history of sudden death of a sister at the age of 33. And then there was provocation with ajmaline, genetic testing, and he is scheduled for EP study and ablation. See, if this patient was taken if he wasn't taken seriously, he would have been subjected for sudden cardiac death. But doing just routine basis, he had syncope, just an assessment, family history, and ECG revealed the presence of second type 2 progada, and that's what, and so he was done into the protocol of the progada. And this is what we are seeking, a standardized approach for every syncope in order to risk stratify patients. Okay, next. While doing patients ECG for patients, don't ever forget to do, as Dr. Amal said, history, examination, family history, ECG. Don't ever forget to do ECG in different positions in high precordial leads, especially for detection of progada, and even doing several ECGs on several occasions, because progada is a dynamic pattern that can appear at certain situations. For instance, we have for patients for patients having fever with a syncope, you should do an ECG. The stratification of arrhythmic risk and of sudden cardiac death in patients with progada is still an open question and remains a priority objective for many research groups. Several items should be taken for risk stratification of patients with PROGADA, the male sex, giving points for every item. Resuscitated cardiac arrest, syncope, family history, spontaneous type, or it is pharmacologically induced. Fragmented QRS should be taken into consideration while evaluating patients with syncope, the presence of early repolarization, ST segment elevation, okay, malignant arrhythmias, genetic testing, and in the end, we should have EP study to evaluate the patient and risk stratify patients suspected for PROGADA. In the setting of PROGADA, we should differentiate between PROGADA pattern and PROGADA phenocopy. Next. So that we don't over-diagnose PROGADA. Phenocopies are PROGADA-like ECG patterns induced by reversible clinical conditions. It has the same pattern classification of PROGADA syndrome, but differs substantially regarding etiology and prognosis. It should be sought to avoid misdiagnosis and mistreatment. We should know the situation, the clinical history of the patient in which syncope had occurred. This is a nice paper I found about a case series. There are two patients with PROGADA that was published as a poster in the JAC in 2020. Okay. Two patients having the one on the left with the PROGADA phenocopy. It was an 80-year-old male patient who had been found to be arrested, and it was due to hyperkalemia. It gave the presence of PROGADA pattern. However, on dialysis, the PROGADA pattern had completely resolved. On the other hand side, we can find on the right side, this is a patient who had cardiac arrest, and on doing ECG after successful resuscitation, he was found to have PROGADA syndrome, and he has a family history of sudden cardiac death. And so we have to differentiate the clinical situation in which the patient had syncope or cardiac arrest. With another case of syncope, we have a 75-year-old woman with a history of coronary artery disease, experiences sudden brief episodes of passing out without warning. During one episode at home, her husband notes she went pale and limp for 5 to 10 seconds, then gasped and woke up confused. On doing an ECG, this is a strip of the ECG, and so in knowing the age of the patient, the history of the patient that she has coronary artery disease, we should think that mostly this might be a ventricular arrhythmias, or we have to ask about the echocardiography, what about the ejection fraction of the patient, but we can proceed for ICD implantation or something like this. But on doing Holter monitoring, which is a part of the standardized approach for patients with syncope. So, next. Yes, this was the key features, that it is sudden onset with no prodrome and short duration and recovery with CASP. But on doing Holter monitoring, next, please. Okay, next. It was found that this patient on Holter monitoring for 72 hours, we found that the patient had episodes of complete heart block. And so this will give us a precise decision how to proceed, what to implant for the patient. Does she need a CRT, a CRT-D, or an ICD, a single chamber or dual chamber? Okay, and so again, emphasizing the proper approach, or the standardized approach for patients with syncope. Definitely, the echocardiography is one of the items, but I mean that not doing Holter would have just got us for a patient with having a poor ejection fraction, for instance. We can proceed for a single chamber ICD, and this will deteriorate the function of the patient. But knowing that she has an AV conduction disease, this will take us that she might need pacing for more than 40%, and so implanting a higher device, a CRTD, would be properly done better than doing a single chamber ICD.
دكتور عزة.
Sorry, I'm sorry for the voice. Yes, our case is a 33-year-old male collapses while playing football. There was no warning. Bystanders report a few seconds of arm jerking. He wakes up confused and sweaty. He was transferred immediately to the hospital. This was his ECG while arriving at the hospital. You can clearly see a white complex tachycardia, a ventricular tachycardia, that he collapsed while experiencing this attack. Short notice here that this was not the first time to collapse during exertion. He reports that he had reporting that this was preceded by palpitation. However, he recovers immediately. Although he had experienced several attacks of syncope that was preceded by palpitation, but however, he didn't seek medical advice and he wasn't investigated for this. And this was his ECG after being cardioverted. We can see a low voltage ECG, a sinus rhythm with low voltage, having T-wave inversion throughout the precordial leads. Yes, with a fragmented QRS that might give us a hint for what is next. Yes, this is true. And so, what is your next step? Yes, mostly we have to complete his investigations regarding echocardiography, cardiac MRI, okay, in order not to miss the patient. And so we can see that easily investigating or doing a standardized approach for the patient from the beginning can help us in the proper diagnosis. Our next case, Mrs. N, she's 29 years old. She has 2 siblings. She reports several attacks of syncope, sometimes at rest and others on exertion. Her ECG was unremarkable. Her echocardiogram shows mild thickening of the left ventricular apex, 16 millimeters in thickness, and upper normal right ventricular dimensions. She gives family history of sudden cardiac death of her father at the age of 29. What is your next step? Okay, her ECG actually is non-remarkable. I didn't have it. I didn't get it. Okay. But we proceeded for Holter monitoring, which revealed this non-sustained white complex tachycardia, as we can see. And then we proceeded for MRI. We can easily see hypertrophy of the apex. Yes, this is true. And we can see even bulging, even on the right side, is not completely normal. It's very weird. She has biventricular affection. Actually, we are still investigating this patient because it was very weird for us Yes, she has a late gadolinium enhancement affection of more than 15% of the myocardium. Yes, next, please. Actually, this case, I've seen it a week ago, and I'd like to have your opinion about it, about him. Mr. M is a 40 years old working in the field of petroleum engineering. He experienced 2 attacks of syncope. One was 6 years ago, and the other was a couple of months ago. It was not preceded by a vagal prodrome. However, during his last attack of syncope, he had fractured bone of maxilla and several facial injuries. He claims that on this day he was fasting with prolonged standing in his prayers with hot weather. His ECG did not show any abnormalities. His echocardiography shows minimally dilated right ventricle with prominent apical trabeculations. His Holter shows infrequent PACs and PVCs, and his tilting table test shows mixed positive cardioinhibitory and vasodepressor response. What do you think so far? Taking into consideration that he's working under critical conditions, that he might be severely injured if suddenly syncoped. Would you consider this after knowing the history of the syncope, that he was fasting on this day and he had a positive tilting table test? Would you consider him a benign syncope or a malignant syncope? Would you proceed just to reassure, or would you proceed for further investigations?
Did he syncope during التيل تيبل دكتورة عزة؟
Yes, he
ولا
syncoped
just
during the tilting table. Yes, and he claims
syncope?
that it was more or less like the syncope that happened to him.
Okay. He didn't confirm that it was the clinical syncope or not.
No. Okay.
الايكو والام ار اي يا دكتورة عزة.
Echo, as I said, it shows mild uh, uh, affection of the left ventricle and mild affection of the right ventricle with the mild trabeculations of the apex. It's not totally obliterated apex. And so I proceeded for the MRI, and this was the result of the MRI. It showed that there is a substrate of arrhythmia with a remote episode of myocarditis. However, it didn't exclude, there was late gadolinium enhancement in the basal lateral wall of the left ventricle. A cardiac sarcoidosis was taken into consideration. It should be excluded. Actually, I didn't expect to have this in the differential diagnosis. Mildly impaired left ventricular systolic function and mildly impaired right ventricular systolic function. What do you think? Actually, I haven't seen the patient after doing his MRI, and I'm just still thinking, what is the next step from your? What do you think? Shall we proceed for an ICD immediately, or do we have to investigate for sarcoid, or do we have to have an EP study?
In all
Patient
circumstances we will take HAMA seriously يعني. ICD I think is an option, a strong option in this case.
I
Even
do agree.
guidelines say APS, but the situation is weird.
I do agree, Dr. Amal. The point is that I'm showing just my aim from throughout these cases, that if we didn't take syncope seriously, we might lose our patient. Okay, this is the issue of this talk, that we
Yes.
have to talk syncope seriously. We have to put the patient and subject the patient for a standardized approach in order not to miss our patients. We can take syncope lightly, as happened with this patient, and say that this is might be a vagal syncope, neurocardiogenic syncope. However, in the end, it proved not to be a benign condition. It is a serious condition. Next. This is how to make a differential diagnosis for our patients, in order how to think, how to approach, how to put the items for the differential diagnosis. No, he doesn't. Someone is asking about if he has something in his in the MRI. Nothing it reports. I'm not sure if I have to send him to have a CT to search, but he doesn't have any chest problems. Okay, next. In conclusion, new technologies, including artificial intelligence and smart devices, may have the potential to reshape syncope management into proactive, personalized, and data-centric model, ultimately enhancing patient outcome and quality of life. The point is that I do agree with Dr. Amal that we have to approach the patient with the standardized approach, but sometimes the syncope might injure the patient, but in the meantime, doing everything, the ECG, the Holter, the echo and the MRI, and we doesn't reach a finalized diagnosis. And so I think there is still a gap between the diagnosis and doing the best for our patients. Thank you so much.
شكرا جزيلا لحضرتك يا دكتورة عز. أنا إيمان سمير مع حضرتك.
أهلا بيك يا دكتورة إيمان.
ربنا يخليك. صعب جدا إن حد يقول أي إجابة للمعلمة الأولى بتاعته، بس أعلق على الحالة الأخيرة بتاع حضرتك عشان في ناس كاتبة هولتر. لا حضرتك علمتنا إن إحنا نبص على الانفستيجيشن في لاترال سكار كبيرة، ما ينفعش المرة الجاية هيجي صدم كاردياك تيست. أنا شايفة إن في ناس كاتبة تسأل على الهولتر وهو في لاترال سكار كبيرة، يعني حتى لو هو عنده 40 سنة وحد هيفكر في كارديو نيورو ابليشن فهو برضو في لاترال سكار وفي سينكوب، والسكار واضحة في الصورة اللي حضرتك جبتيها. في صورة جميلة كده حضرتك جبتيها فيها لاترال سكار يعني.
يس هو
أعتقد لو هو ديوال اي سي دي زي حالات الساركيدوزس برضو الديوال اي سي دي هيكشف يعني هيعالج في نفس الوقت لو هو في كارديو انهبيتور سينكوب، وفي نفس الوقت هيفيده عشان البي تي اللي بتيجي من السكار دي.
I do agree with Dr. Iman for this. It shouldn't be taken lightly. الهولتر الحقيقة ما طلعش حاجة. الهولتر كان just we have infrequent PACs and PVCs, and this doesn't exclude the severity of the condition.
في اللاترال وول هنا باين ان حضرتك خاصة في الشورت اكسس فيه سكار كده سب بيكارديال تقريبا.
Yes.
الشورت اكسس نفس اللي بنشوفه في الايكو كده في المكان بتاع اللاترال وول، برضو في الابيكال فور تشامبر اللي هو
دكتور إيمان speak in English please.
Okay. In the second picture, in the middle picture, there is the lateral wall scar appears, and in the short axis, in the third picture below, there is also a subepicardial scar. Yeah.
Yes, this is true.
Reflecting high risk patient. Yeah.
Yes.
And the condition of cardiac sarcoidosis, he will have a conduction disturbance in the future, and although if he is having cardio inhibitory syncope, that's all the three causes will lead to putting dual ICD. I think yeah, as I think this case.
Okay. Dr. Rana, can you help me in this?
I was stating that the scar burden is part of the HCM risk stratification guidelines, but not yet in other arrhythmogenic cardiomyopathies.
I
ICD.
think actually, Dr. Rana, I've revised this item for sarcoidosis because, as I told you, I met this patient within the last few days. Actually, they are putting the for sarcoidosis, especially for the ventricular arrhythmia guidelines 2022, more than 22% late gadolinium enhancement is considered high risk.
Yes.
Just in precision, I've just revised this recently. For especially for this patient, but actually he did. Yeah, the MRI.
Not a confirmed case of sarcoidosis.
Yes, it's not that confirmed. Yes, this is true.
Yes.
Yes,
It doesn't look like sarcoidosis to be.
Even there is the arrhythmogenic substrate, Rana. Dr.
Yes.
Rana.
Yes, of course. I mean, in cases of arrhythmogenic cardiomyopathy, it's still not part of the guidelines for risk stratification. It's going to be, but not yet. And I have like lots of cases with arrhythmogenic cardiomyopathy, and we did quantify the scars, and I had like around 25% of my patients with ICDs, even ones for primary prevention, not for secondary prevention.
Yes.
But this patient with high risk syncope, which looks arrhythmic in origin, and this scar, I guess, yes, we could go for primary preventive ICD, and then it would be a monitoring for the correlation with the symptoms if any sustained VTs occur.
I agree with you, Rana.
Yes, but we were someone was considering dual chamber ICD. I'm not sure why.
No.
Yes.
Maybe they are considering the progressive course of the disease that he might not need pacing. The point is that what I want to emphasize in this case, that not to take syncope lightly. This is the main issue, because it could have been posed as a simple syncope after saying that he's fasting, he's standing the whole day. It might, although he didn't give a vagal prodrome. But this is what I needed to emphasize in all the cases I've shown, that just takes things seriously. If it proved to be benign, well and good. If not, this is what I mean.
Dr. Ahmed was saying to exclude ischemia-induced. This cardiac MRI has a transmural and most probably mid-myocardial to subepicardial scar, which is not going along with ischemia. It could be endomyocardial. That's why the cardiac MRI did a huge job in this patient. And they were concerned about the CT because of the hilar lymph nodes and their correlation to the sarcoidosis.
I think I haven't sent him for CT, not yet, because I didn't expect sarcoid to be one of the differential.
Yes, it's very uncommon to be isolated cardiac. It's very uncommon, but I do have one patient with isolated cardiac sarcoidosis. And
Me too. I'm presenting with ventricular arrhythmia, which is very weird. Yes.
My patient had complete heart block along with ventricular arrhythmias, both. And a phenocopy of HCM, like the echo was HCM to start with, but the abnormal finding was the complete heart block, which was weird for HCM in isolation.
I think I would have thought about infiltrative diseases for this.
I did. That's why we did the cardiac MRI, and then we did screen the whole family. And the father is symptomatic. One of the siblings is early affected, and we are closely following up this family.
I do agree with you, Dr. Rana, that by the way, sometimes I was discussing this with Dr. Amal. The point is that sometimes the first presentation is conduction disease, and nothing else. When we see it in the young population, 30s, in the third and fourth decade, we have on follow-up, you might discover that this was just the starting point, the conduction defect or the ventricular arrhythmia, and then the full-blown picture will appear within few years.
Yes. Very nice cases, Dr. Azza. It was a very nice discussion. And some of the patients, or most of the patients, had a red flag, even if one of their episodes was benign or looks benign. But most of them had no prodrome at all, or all of them had no prodrome at all.
Yes, this is true.
Most of them were during exercise. So the whole red flags that we were discussing are still there, even if the patient is stating, no, I was fasting, no, it was a very hot day, no, it was prolonged standing. That's the patient's own explanation for the syncope. It should not be taken in isolation, especially in this patient, in one of the patients who had a sister died, and he didn't state that before the ECG finding, because he wasn't asked about it. So if we did not ask about the family history or the previous symptoms, we could miss this.
I think in Egypt and in African countries, and this is the purpose of the lecture, because it's a specialty for our countries, there should be different approaches. Most people, as we have seen in our case, the man working in Italy and he's Egyptian, and I've seen it several times. They have family history of sudden cardiac death, and it passes smoothly as if it's just an event.
Yes.
Which is very weird. This is my third case for Progada, seeing the same way of thinking, that the patient arrested or had syncope, and then when you ask about the family history, you find someone in the family who died suddenly, the brother
We have
or
this
sister.
problem with the children, because they consider infants who die, that's a normal event. Like yes, his sister died at 3 months of age. His sister died at 9 months of age. They do not consider this a sudden cardiac death. They just consider it a misfortune, and it
Yes,
happens a
it
lot.
occurs very, very frequently, this
Yes.
this case, yes.
Mhm.
Yes.
Your case, Dr. Azda, highlights also the importance of awareness, which is our mission in Africa,
Yes,
inshallah.
this is true.
This patient highly qualified, يعني, well educated, aware. It's he is aware of risk of sudden cardiac death. He diagnosed already. He is vasovagal. Um, because of his awareness of sudden cardiac death, he seek another opinion and goes other track. So the importance of the awareness of sudden cardiac death is very, very, very important.